Good morning, everybody. Uh, Really thankful, and I'll directly go to the my talk on LDL-C, which is one of the most talked component forever in cardiology, and the targets are getting lower and lower. So I'll not waste much time, and I will go directly to my talk. Why it is important in India. Indian Asians, South Asians are being one of the highest risk of CADs or cardiovascular disease, including strokes, peripheral artery disease. So it is important to know what are the targets and what are the weapons right now available in October 25 in our basket. Yeah. So global cardiovascular disease challenge is there, and we all know it is a leading cause of death. Why it is important? It is leading cause of death, but in all the chronic diseases, it is one of the most preventable and well-treated cause of death. If you see the other chronic diseases, the patients of cardiovascular disease will have a better morbidity. So it is very important to identify and treat the cardiovascular disease. There are good modifiable risk factors which can prevent, and if we see the every reduction of 40 milligram deciliter in LDL, we will reduce the 20% risk reduction in cardiovascular diseases. Among all the risk factors, LDL or cholesterol has been, lipids has been one of the most important contributor to the cardiovascular diseases. So it is important to take care of the devil. Why in India? If we see the Indians, as Dr. Dharmesh Bhai rightly told, the estimated prevalence in India is very high. Almost 55 million patients are suffering from the cardiovascular disease. It is number one killer, as we saw, high cost burden. But what is important compared to Western population, they have a higher risk factor of cardiovascular disease. It is developing at early age. It is more severe form of the disease, so higher morbidity as well as higher mortality, and it shows poorer outcome. So it is very important in Indians, being Indians, to know and treat the cardiovascular disease. If we see even Indian trials, most of the trials shows, even Jaipur Heart, Indian Heart, the incidence of dyslipidemia, high LDL, is anywhere in the range of 30 to 50%, particularly higher in urban Indians compared to rural Indians related to lifestyle. But if this high incidence of LDL is there, then we have to hit it with hard also. Okay. So what is important? LDL pattern is different in Indians compared to our Western world people. We have high small dense LDL. Why it is important? Because high dense small LDL is a oxidized LDL, and oxidation of LDL which promotes the atherosclerosis or plaque deposition. Okay. We have even high triglyceride levels and low HDL levels. Nowadays, lipoprotein A is also becoming more and more important. We have high lipoprotein small a, which is compared to the other Western part of the people, almost 25% in Indian population in studies have shown. So why it is important? There is one more concept which we all should know, that is cumulative LDL. The total LDL which we are having for over the years, if somebody is 50 years and his LDL is 100, then cumulative LDL we can calculate. So in patients who are having this pointer is not working. Yeah. Yeah. That is there. But so if we see patients who are having familial hypercholesterolemia, patients who have genetic high cholesterol levels, they have higher risk of getting earlier coronary artery disease or atherosclerotic disease compared to. So it is important that lifelong LDL-C we keep in check the lifelong LDL-C, which is lower. So we need to know the targets. So what does recent guidelines says? Recently ESC has come up with the guidelines. So I am going to stick to the ESC because my colleague Dr. Satyam is going to speak about Indian guidelines. So let us see what European guidelines are saying these days. So risk estimation purpose is basically for the reduction of the risk in high risk individuals. So they have used score 2 calculator and score 2 OP. OP calculator is mainly for the elderly people more than 70 up to 90 years. Another important thing is they have used non-HDL-C instead of total cholesterol, because HDL is a good cholesterol. So it is always important to look for the non-HDL cholesterol. Okay. So what are the risks they have divided? Very high risk. We all know documented atherosclerotic disorder, they are all very high risk. In diabetes, important is diabetic patients with any target organ damage are high risk patient. Diabetic patient with multiple risk factor is again very high risk patient, or early onset type 1 diabetes which is lasting, or patient is having type 1 diabetes more than 20 years. These are all very high risk patients. Any CKD patient with eGFR less than 30 is high risk patient. Score 2 or score 2 OP risk 10-year risk more than 20 is again high risk patient. Any very high risk patient. Any family history patients of atherosclerotic cardiovascular disease with another major risk factor. Any patient who is having a family history is meant by premature coronary artery disease with another major risk factor, they should be considered very high risk patients. So we will go back to the, we'll see what are the targets later. So these are the very high risk patients. Important is diabetic patients with risk factor with target, multiple risk factors with target organ damage or type 1 diabetes. What are the high risk patients? Any risk factors which are markedly elevated, any family history of premature atherosclerotic disease but without risk factors. Diabetic patient without target organ damage are high risk patients. Diabetic patient more than 10-year duration, or any diabetic patient with risk factor, they are high risk patient. Moderate CKD patient, again very important, they are high risk for atherosclerotic disease. Score 2 risk of 10 to 19% are again high risk patients. What are the moderate risk patients? Diabetic patients of type 1 less than 35 years, young type 1 diabetic, type 2 diabetic less than 50 years, duration of less than 10 years of diabetic, no risk factors. So these are the moderate risk patients with long-term risk of 2 to 9%, if again moderate risk, low risk are less than 2% patient. Why this is important? Again, in many of our practice, I will emphasize one thing. In diabetic patient, lipid profile is must, and if we see all these guidelines, most of the patient who are having diabetic, they will need some form of statin, okay, because the targets are such that we need to treat the or get the goal. Yeah, thank you. Another important is risk modifier. If we have this modifier risk factors, then our risk goes one step higher. Why I have kept this is because of high risk ethnicity. So whatever risk we are sitting at present or our patients are at present, we have to put one step higher or one risk category higher just because of we are South Asian people. Okay. Then again, physical inactivity, stress, all this obstructive sleep apnea, any persistent inflammation like high hsCRP or elevated lipoproteins little a, they are all immediately goes to one's risk category higher. Another important, just I want to stress, is a coronary artery calcium. Again, if any patient whose coronary artery calcium is more than 30, they automatically goes to atherosclerotic cardiovascular disease as a secondary prevention. So they goes to directly to the very high risk category group. Okay, calcium score of 0, again the category group is reclassified to one category lower. Okay, so these are the risk groups. One more thing I will show here is an extreme risk patient who are having atherosclerotic disease but having recurrent any atherosclerotic events, I mean cardiovascular events, or any patient who are having multiple involvement of vascular structures like coronary artery disease, peripheral artery disease, stroke. They are all extreme high risk patient. Okay. So now what are the targets? Where do we go according to them? The LDL target is, previously it was 190. Now they say even low risk category 116 to less than 190. All these patients should be asked for lifestyle modification and adding drug if it is uncontrolled. So any patient whose lifestyle, after lifestyle modification, if their LDL is more than 116, we should consider adding medicine. And drug generally to start with will be statin. All other people should be given lifestyle advice. If any patient who is in moderate risk category, if LDL is more than 100, then they should be advised lifestyle modification and add drug if uncontrolled. All high risk patient targets are less than 100. Okay, so if there is any patient, moderate risk patient category, they should be given a lifestyle modification advice if LDL is more than 100 and add drug if it is not getting controlled. Very high risk patient, again the targets are less than 70 for primary prevention. Primary prevention is patient who does not have any documented atherosclerotic coronary artery, I mean cardiovascular disease. They all should, if there is a more than 70, they should directly be sent for the medication. Okay, and less than 100, then lifestyle modification, but target should be less than 70. If if it is if all the very high risk patient LDL level is more than 70 after doing all the lifestyle modification, then they should be given the drugs. Secondary prevention patients, their target is less than 55. So all the targets are coming lower and lower. So one question always comes, is it safe to have such a lower cholesterol? Yes, if we see the trials, if cholesterol levels are lower and lower, the risk of vascular events are lesser. The more the cholesterol levels, the vascular event, one vascular site, two vascular sites are higher. So it is better to have lower cholesterol. Even trials have shown there is no neurocognitive or other effects if targets are even less than 20. Okay, and generally intracellular cholesterol levels are tightly regulated, so it is the cells are not dependent on circulatory cholesterol. What we are targeting is a circulatory cholesterol, so lower is the better. So what are the weapons we are having in our basket right now? We have different weapons and the good part is that all our weapons right now are working at a different mechanism of action. So statins work on HMG-CoA reductase inhibitor, bempedoic acid, again ATP citrate lyase inhibitors, our ezetimibe works on Niemann-Pick C1-like receptors from the intestines, and newer drugs like PCSK9 monoclonal antibodies or PCSK9 inhibitors like inclisiran, they work on PCSK9 inhibition. So we'll go to them one by one. Most important is statin. As we all know, high intensity statin is very important to achieve the targets. So one thing I would like to stress here, it is the targets which we need to achieve, which we need to see. Not that all the patient who had a atherosclerotic disease, we are giving 20 milligram statin and that's all. Most of the people, we do not stress on the targets. So it is very important to stress upon the targets. So statin, there are so many landmark trials. I'll not go into much of the details because we all have seen so many times. Okay, so but what are the current gaps? Why we need to have another drugs, another medicines in our basket? Because despite statin therapy, different trials have shown there are residual risk. So statin alone is not able to reduce the risk to the fully. There are poor adherences to the statins. We have seen one standard deviation increase in LDL. It increases the coronary events by almost 10 to 20%. Another important point is the longer we control the LDL, the better we get the results. More and more reduction in the risk is there. So it is important that we control the LDLs for as long as possible. There are statin intolerance, we all know myopathy and rarely rhabdomyolysis. So again, there are patients in anywhere in the range of 20 to 40% in different trials where they have shown statin intolerance. If we see real world evidence, almost 80% of ACS patients do not reach the target, 80%. So this should be one eye-opening data. Okay, if we see at 1 year, this only 20% of the patients did reach the target of less than 55. So again, important. Why it is important to achieve less and achieve the targets? Because it also decreases the atheroma volumes. Early aggressive statin in ACS patients, they have shown to reduce the risk by almost 20 to 30% of the patients. So it is important to give early aggressive statins. So what are the novel methods we are having? One is ezetimibe. It is Niemann-Pick C1-like receptor inhibitor which are there in intestinal brush borders. It is very good FDA approved agent. Monotherapy achieves almost 18% reduction, while adding to the statins, they achieve almost another 23-24% of the reduction in the LDL. We have to be careful in hepatic patients or hepatic dysfunction patients with moderate or severe impairment. So this is one drug, and it improved IT trial, it showed when it was added to the simvastatin, it showed further reduction in the MACE. So it is not only reducing the LDL, it is important that it is reducing the mortality as well as morbidity benefit also. So another important drug which is available these days is bempedoic acid. It inhibits ATP cyclase inhibition. It does. Important thing, it is adding LDL reduction over and above statin. One thing I would like to highlight is it is working in the same cycle just above the statin. Statin inhibits HMG-CoA reductase inhibitor. So there are data which are coming up in the bempedoic acid that it may have effect as a good anti-inflammatory effect also. So maybe the pleiotropic effects of statin, bempedoic acid may add upon because it is active in the same cycle. So it may increase the uric acid and risk of tendon rupture. So elderly patient who has past history of tendon rupture or any patient who has who is on steroids should be given little carefully. So clear study trials showed MACE benefits as mortality as well as morbidity benefits. PCSK9 monoclonal antibodies evolocumab, again it is one of the important drug which reduces the it inhibits the PCSK9. By inhibiting PCSK9, what does PCSK9 does? It attaches to the LDL-C receptor. LDL-C receptor is actually pulling back the LDLs from the circulation and destroying in the liver, so removing both from the circulation. So by inhibiting LDL-C receptor, it allows the more and more LDL to remain in the circulation. So by inhibiting the PCSK9 receptors, it will allow more LDL-C receptors to be on the surface to pull out the LDL from the circulation. So again, there have been shown different trials, Fourier and Odyssey trials, which have shown mortality and morbidity benefit. Because of the time, I'll go a little fast. Inclisiran, the new drug, which again, it reduces the PCSK9 production, inclisiran. So it is little different from the evolocumab, and it is siRNA inhibitor. Orion 10 showed significant, almost 50% reduction in the LDL levels, as well as Orion 9, 10, 11 recently have shown mortality as well as morbidity benefit. So, and again, one more important thing, it doesn't, inclisiran has shown to reduce even ApoB, lipoprotein little a, and it has shown to increase the HDL levels also. Not many drugs are effective in lipoprotein little a reduction, so it is again one important thing which we should look in the future. So the good part is that it needs to be given only twice a year after giving first and second dose at 3 months. Okay. Again, only thing is cost is a prohibitive right now. So can we start combination therapy? Yes, all the patients who are coming with ACS, if their LDL levels are high, these are the amount of LDL reduction which is achieved by different drugs. This slide is very important. If patient is coming with 170 milligram per deciliter of LDL with ACS, even if we start high intensity statin, we are not going to get his target to 55 or below 55. So such patient combination therapy should be initiated. If we give good amount of all the drugs, we can reduce up to almost 85% of the LDL levels. So combination therapy is way to go in such patients. Okay, and future evaluation, hopefully something which comes gene editing, which trials are going on, and once we do, we will be all safe for the lifetime. Hopefully that comes in the future. So my take-home message for LDL is very simple: lower the better and try to achieve by all means. Thank you.